Thanks very much for the meeting organizers for the opportunity to participate. I think this will be an interesting session. We're very fortunate to have Brent here with us, as well as my good friend Heber Crockett, to discuss from the provider's perspective, the payer's perspective, some of the challenges that we're currently facing in introducing new technology to institutions. So we know, of course, there have been rapid changes at institutions for the process of introducing new technology. And institutions clearly understand that the revenue portion of the equation is flat to declining, and the opportunity to pass on the costs of new technology is rapidly evaporating. So currently at the Mayo Clinic, we're essentially 100% fee-for-service, and the expectation within the next 5 years on our finance committee is that there'll be a dramatic shift towards capitation. The number that we've been discussing is 70% capitated within the next 4 to 5 years. So very, very dramatic change in the way we're reimbursed for services. And really right now we're in a state of semi-controlled chaos where institutions such as the Mayo Clinic and others are trying to anticipate the changes in care delivery, as outlined in the previous speaker's talk as well. So will future reimbursement be based on accountable care organizations? Will it be based on bundled payment for procedures? This is really up in the air. What will be the impact of having this huge increase in the number of Medicaid patients? At our institution itself, of course, that the Medicaid patients we take care of are an enormous source of money loss. And how about what will the effect be of insurance exchanges? So one impact for sure, of course, that our institution and others are planning on is this decreased reimbursement going forward. So what are the results of this uncertainty? Well, there's significant pressure on device pricing. I'm a part of the group at the clinic that decides the pricing and the contracts for devices, and enormous pressure in that regard now to hold the line or result in price decreases. And other aspect, of course, is my institution as well as others have really become a part of these very, very large purchasing organizations. There's also considerable efforts to limit the number of vendors. That's something that's actively looked at, and also a demand for increasing discounts. And one thing, of course, that we're seeing is that really there's been a part of trying to limit the introduction of new technology, particularly expensive technology. The other aspect we've noted is a very limited view of time in patient care. Instead of viewing this as years, this is viewed as months in terms of looking at monthly expense reports and how do you manage that in that regard. So here's just a couple examples that I thought I'd share with you that highlights this. This is a gal that I helped with. This is a 56-year-old woman. She sustained a proximal humerus fracture. She had significant arthritis, a rotator cuff tear. She has the inability to raise her arm, and she has significant pain. And she was sent in. You can see she had an attempt at a fixation there. This patient has end-stage arthritis of the shoulder. Her rotator cuff is torn, and she underwent a reverse arthroplasty of the shoulder. But the question is, in this young gal who's 56 years old, do we use an advanced bearing surface, such as E1 polyethylene at the time of surgery, which increases the cost of the procedure by several $100s? So what are the positives? We know that wear, of course, is a limiting factor in joint replacement surgery. There's good data that shows there's a 90% decrease in wear in labs with the use of E1, so there's significant promise in the shoulder. The problem is there's no specific data for the shoulder, and it's a $500 increase per case. So do you use the advanced bearing surface, yes or no? So there's this debate going on, the potential for long-term cost savings versus the short-term increase in cost. So I think at the end of the day, the way to think about this, in 2001, the decision maker was the surgeon. In 2012, it's changed rapidly. It's the surgeon, nurse manager, OR manager, and hospital, all who have equal say when new products are brought forward. So the balance of power is clearly shifted, and I can tell you it's accelerating right now, particularly in the light of the number of physicians that are now employees of hospitals. This has changed a lot of the power dynamics. So I think when new products are brought forward, it's critical that you have to appeal to all the stakeholders involved. For the physicians, we want devices and procedures that are time efficient, competitive advantage compared to other groups, and simple reproducible techniques. The nurse manager, who has tremendous influence, she wants to limit the number of systems, so she has to train less people in the operating room and less instruments on the shelf. And for the hospital at the end of the day, although cost and time are important, safety and quality are number one. I'll give you an example. So this is an example of patient-specific instrumentation. I don't know how many of you have heard of this, but there's a trend in hip and knee arthroplasty to be able to make guides specifically for an individual patient. But it requires an MRI or a CT scan, which you typically wouldn't get for a hip or knee arthroplasty. So you have the cost of the imaging and then about another $1,200 or $1,000 increased cost for the guide. So the hospital has to eat that cost outright. The benefits that surgeons like myself would talk about: increased OR efficiency, faster OR time, and less instrumentation per case. But at the end of the day, the one benefit that really secured approval from my institution as well as others is the improvement in patient safety and quality and decreasing malalignment, decreasing outliers. So it's a quality issue. Another example, soft tissue grafts are used extensively in soft tissue reconstruction. One of the products out there was terminally washed with a theoretical risk of disease transmission. It was interesting that when we approached our institution with this, at the end of the day, the one aspect of this that secured approval was this device was sterile. So just a theoretical increase in safety allowed this to be approved. So I think at the end of the day, we clearly have seen the power has shifted. The customer is no longer just the physician. It's all the team members at the hospital. You need to appeal to all the stakeholders and understand the issues that are important to each of those stakeholders. And it's very important to arm the physician champion that you're working with information to appeal to all of these stakeholders and develop this type of strategy from the beginning of the product development cycle and look for opportunities to communicate this effectively. Thank you very much. Our next speaker in this session is my good friend Heber Crockett, and Heber is going to give us a different perspective moving from academic medicine to private practice. Heber.
Well, I appreciate you all letting me be here, and couple of things I've noticed about this meeting versus a medical meeting is I don't know anyone here, and the second is you guys dress much, much better than surgeons. So can't believe all the suits, so I apologize for my under preparation in that area. Just a bit about myself. I'd like to say I went to Yale, but that's actually BYU. I apologize. And medical school at UCLA. Like John, we trained at the Hospital for Special Surgery in New York, and then I spent a year down with Dr. Jimmy Andrews in Birmingham to do sports medicine. John, one of the great things about HSS is that it's a really connected place in orthopedics, and you get to kind of set up your career from there, and it's fun to watch what people do. And in John's case, he went to the Mayo Clinic, as a lot of the guys do, go to great institutions, and I've appreciated watching him succeed there and follow his dream. And I think he's celebrated me following my dream with my clinic in Nebraska. And it's kind of like the Mayo Clinic, but different, and different departments. As a California boy from the Bay Area, we've learned new things about the state. One is that Kearney, Nebraska is 1,733 miles from Boston, and it's 1,733 miles from San Francisco. So if you hate the beach, you should come live in my town. And also there's some cultural changes that aren't in the Bay Area. There's one team that you root for there apparently, and it's an academic institution, so they're very proud of their academics. So, like John, when I started in 1999, life was pretty simple, and you would go to clinic, you would do surgery, you would bill your patients, you'd take care of the people in the OR. And that was 100% of our income in 1999. That's exactly what we did. And I think an average shoulder surgeon, a sports surgeon will do about 150 shoulders, 200 knees, 20 elbows. And my 2011 numbers are a bit higher, they're in red. And our practice has gone very, very well since that time. But what's interesting about our practice is, let's see if this will do this. So in 2012, here's the differences. So like John, I think the landscape has changed. And so we have things now. We have our own building, an ambulatory surgery center, durable medical equipment that we sell through the office, PA services, physical therapy, which we own, imaging, which we own, pharmacy, which we own, itinerant clinics, which we have. And actually, all of these entities now make up 45% of our income in the practice. And so even with a large caseload over here, it's a real important thing as reimbursement goes down to have these other avenues to make up some of your revenue. And so I think aggressive groups will do that, and I think we're probably one of them. There's a lot of unanswered questions, and I think as you guys deal with physicians, certainly in the private practice, that are different than guys already employed at the hospital, there's a lot of trepidation, there's a lot of fear about what's going on. And so one of the big issues is, as John's mentioned, others of today, ACLs bundling, partnerships. There's guys out in Nebraska that want to partnership with our group. Let's get 5 cities together, and there's 18 cows and 9 people, and let's just get together and dominate this area. And they want that security of being together and billing under one code. And so a lot of guys are so sick of the business side of it that they feel they've lost the pure practice of medicine. We went to medical school, this is horrible, we're this weird kind of business invariant, we don't know what we're doing. And I hear that all the time. And so we're looking at contracts, you're looking at what is the government's role. And I think really that there's a lot of instability in the private market. People don't know, and surgeons aren't sure what's going to happen. And with a lot of the regulations, the burden falls upon your practice. It falls on you, essentially. And so what I used to have were monthly meetings in 2001 or 2. They're weekly meetings, and it's to manage all this other stuff that has nothing to do with being a shoulder surgeon or anything else. And then the government asking us to get this done, restructuring Medicaid. And we've calculated in our group it's about 400% the work to get the same payment from Medicaid. ACOs, who's going to divide this up? Is it the family practice guy? Is it the surgeon? Who's going to make these choices? And that falls to us as well, as been talked about before. And then as we've talked about the Sunshine Rule and the crackdown on these ancillary services. And so we're involved in all of this stuff. And the Sunshine Rule is going to come out. RAC audits are on their way. And so as you look at this, with the government and the pressure that puts on a private practice, you end up, and our COO said, every change forces a medical practice to find more specialized staff with certain skill sets. This is so true for us, and this is our own COO. It's always evolving. We need knowledgeable people to navigate the playing field and dodge the bullets. Not enough just to bank the money, do payroll, handle employees. The healthcare climate is punitive if a practice doesn't pay attention and isn't prepared. And I really do believe that's true. And I think with the government giving us different things and pushing us and making things, we got to go a long way to get any benefit for things. And I think we often don't communicate appropriately. And so I think with things like this, we can get into some trouble. So one of the refreshing side is we look at the opportunities kind of with VCs and the stuff that you guys do. I think that, my 3 rules, not that I've learned all this from Dave Stassen and other people, but, can you save the patient money? Can you save the insurance company money? Can you create a revenue stream for the physician? And I think there's still opportunities. I don't want to be too, pessimistic about this, but this is actually our surgery center in the cornfield. But, anything more efficient. EMR is really painful for us now. In-office procedures that reimburse, outside stuff that you can do here. Low-cost implants, a lot of pressure, as John mentioned, on getting implants down. Any implant that we pay for is money out of our pocket. So I think there's a lot of pressure for, generics or even no implants. Tourniers kind of have a deal like that where they have no implants. Bundling a project, we get approached by different companies like this one and say, listen, if you will use only our implants and kind of kick everybody out, so we're going to give you a cut rate price. So there's a very aggressive kind of behavior towards getting this done. And so people are doing different strategies. And I think also there's a big market for leveraging the ideas of physicians themselves. And I think that I was one of those guys a long time ago and had an idea, and as physicians often do, they'll draw from things that are around them. And when we started Cayenne Medical, and I'm one of the founders there, we made this device, and this was for an ACL reconstruction. And since I'm around corn, kind of looks like corn, and people, I think, draw off what they're around. And so a lot of physicians have come to us and asked, what are you doing, how do you do it? And they bring their ideas, and as you guys know, all ideas seem great to the physician. You guys have to decide, is it cute to them or just cute to them only? And so, at times you don't know these things. But it's been a great thing for me. These are 5 companies that I've actually founded. I'm also involved in other companies in all these different markets. And it's really been an astonishing, fun time for me to be involved in things that are outside orthopedics. My wife, who is a graduate of Juilliard in piano in New York, says this is your right brain kind of outlet for this kind of big, boring practice that you have. And so I've really enjoyed it, and I enjoy having time to be with you guys today. So thank you very much.
That was outstanding, Heber. Thank you very much. Next, we're going to have Brent speak with us. And Brent has enormous experience, having worked with Blue Cross Blue Shield for many years in looking at the introduction of new technology and really from a payer's perspective trying to give us some insights into what we can expect going forward. Brent?
Hi, everybody. A couple of things I have to tell you first. I am not a surgeon, thank God. Secondly, I dropped the first baby I ever delivered. And that's why you put buckets at the end of the delivery table. Third thing, I didn't know whether to wear a mask here or Kevlar, because all of you as investors or investors in technology anyway, I've had some contact with you over the years. I served as the chairman of the National Blue Cross Medical Policy panel for 6 years. And virtually everything that came out of that panel had my name on it. So I was the guy who had the either dubious pleasure of covering your products or turning them down. I also, at my plan level, put the prices on what we paid for technology. So some cases I had my heredity questioned. In some cases I was called a Nazi once. But honestly, when we approach technology, there is a really good way that we do it. And where's our clicker? Right here. Okay. From the payer perspective, technology can be good or it can be bad. The first thing that you need to appreciate, and all of you know about the FDA approval, in the Blue Cross and commercial system, having an FDA approval is the cost of admission to the game. Okay, if you don't have the FDA approval, you can't even get an appointment to talk about your products. Secondly, the FDA is considered by the insurance industry to have limited scope. And it only takes really a look at, is it safe and is it effective? And the insurance industry are more interested in long-term outcomes and when and where you use the product. Keep in mind that the insurance industry can either impede or encourage the diffusion of technology, depending on how they perceive that technology. Good example are all the high-end radiology products, CT, MRI, when they first came out. My company actually increased the prices of all MRIs, CTs, and the reimbursement to the physicians, and I'm from Pennsylvania. What we wanted to do was diffuse that technology out to the hospitals, the 158 hospitals in the systems in Pennsylvania. Then, admittedly, 5 years later, we started to ratchet back. But that is the way that insurance companies work. They either want to increase the technology or impede the technology. And there are a variety of ways that we can do that within our insurance contracts. CMS is a little bit different. They rely heavily on the FDA coverage. Okay? So you have to remember there are differences. All of you are familiar with the types of studies that are required by your companies that you've invested in. Many of the and by the way, I'm on the board of directors of a company here in Shoreview, and it's been a great pleasure to be on that end of the spectrum. But there are different types of studies that carry different weights for the insurance company, and obviously we would like to have all studies done as randomized, controlled, matched studies, and unfortunately that's not possible. So you have to rely on all sorts of other studies. Some are good, some are good in certain circumstances, some are absolutely bad. I had a client once who called me and said, I have a great product. It's a continuous passive motion machine for the toe. And I said, you know, I've never heard of a continuous passive motion machine for the toe. Knees, yes. Toes, no. And he said, well, I have 300 articles. And I said, tell you what, send me your best 10. I'll look at the articles, and if there's something there, we'll represent you. And what he sent me were 10 individual chiropractors praising the use of this device. And obviously that has no use at all in terms of the insurance industry or even science. So we didn't represent him. Most of the kinds of people that I represent, the people you invest in, have a very good idea of what they want to do and how to do it, and quite frankly, have very good studies behind them. They run afoul occasionally of certain small things that's peculiar to the insurance industry. I've already mentioned FDA approval, for example. I was going to mention the particular company that I'm on the board of directors, but I probably better not. Any event, I was representing them at a large insurer yesterday in Dallas. And to peel back the curtain a bit, this insurance company is the second largest blue company in the United States. And we had our pivotal trial and another trial, and went down and discussed it with the 4 medical directors from this plan. And the medical directors were cordial, loved the technology, and their only question was, gee whiz, we don't know how to code it yet, okay? But insurance industries now, much more so than previously, are open to discussions with your companies. Your companies need to know, however, how to arrange that, how to get inside of those insurance companies. I can tell you with the 20 years that I've been doing this, there are good ways to get inside companies and not so good ways. I have parlayed my Blue Cross experience into having over 70 insurance physicians work for me. So I can pretty much, and I'll make this statement, I can pretty much anywhere in this country get inside any insurance plan and talk to them about your product. That's how you do it, okay? It's not necessarily studies, it's relationships. All of the technology review organizations that there are in the United States have the same 5 criteria. Here they are. The difference is they have different ways of interpreting what you see written in front of you. So whether it's ECRI out of Philadelphia, or Hayes out of Philadelphia, or the Blue Cross Blue Shield Tech in California, or in Chicago, or CTAF in California, they use the same criteria, but will come to different conclusions on the same technology based on the same information. So it's not a slam dunk to go before these kinds of organizations. You have to have your ducks in order. You have to make sure things go the way you want to, okay? The hardest one of these 5 criteria is number 2, surprisingly, because the technology review groups narrow what they're going to look at, narrow the types of studies to include, narrow where the publications can be made. So for example, they will gladly accept studies that are in the New England Journal of Medicine, but the Ethiopian Medical Journal is somewhat suspect. And you can understand the whole thing there. You have to also have organized medicine support when you go to get coverage, okay? The AMA CPT is a political animal. It is not objective. It has been under heavy criticism and scrutiny because of the way they approach giving coding. I hope that will change, quite frankly, but I am not optimistic because of the political system. There are different codes that you can get. Obviously, you would like a Category 1 code, which means everybody uses it and accepts it. Category 3 codes or non-NOS, or that should be not otherwise classified codes, can be useful, can be helpful, but Category 3 codes sentence you to non-coverage for the most part for at least 4 or 5 years. So I would encourage you not to think about a Category 3 code. S codes are primarily for Blue Cross groups, and they are used primarily to deny coverage. KOLs, key opinion leaders, we all have them when we go to try and get coverage. I will make a plea to you to make sure when you select KOLs for your companies, that you do a little bit of a background check. Every insurance company is a great data source and has, I am sorry to say, more information about each individual doctor than you would ever want to know. So if an individual doctor has ever stumbled in his path through medicine and gotten indicted, or, had anybody ever question what coding he used or how he used it, it all appears on the databases. And I've had KOLs come in to visit me representing industry who have been convicted of fraud and things like that. And any good medical director in industry right now, in the insurance industry, does a background check on everybody who comes to see him. I'm no different. I do the same thing. So you have to keep that in mind when you're going before the technology review people, okay? Here are some insurance twists I'd like to tell you about. Every one of the contracts we have least costly alternative language in them. They don't necessarily get enforced, but they're there. There's also a clause that says you can't do anything for the convenience of the patient or the physician. That's many times is used to deny something. Conditions of coverage can be tailor-made to an individual. For example, bariatric surgery claims, most plans now have the requirement of 6 months of psychiatric care, documented psychiatric care, before they will allow bariatric surgery. So the policies, the insurance company will say, yes, we cover bariatric surgery, but the nitty-gritty is how and when, and that's how they take care of some of these situations. You ought to know your payer. Are you going to him with science, or are you going to see him because of your relationships with him? Are you presenting to him science, or are you presenting marketing information to him? It makes a difference. I will ask you the question, can you use the payer's own system to help you get coverage? Yes, you can. You just have to know the system. You have to know their processing system, okay? You can recruit support from within the insurance industry because, like the two physicians who have spoken before me, most physicians in the insurance industry are vitally interested in patient care. So you can recruit a lot of support among physicians within the insurance industry. They are open to education. I bring physicians in all the time to educate them on products. And again, I have 75 physicians who are willing to listen to that education. So there are numbers of ways that you can have your companies succeed, even though reimbursement is a challenge. But by knowing the companies, knowing their products, knowing how to present them, and getting some support from industry and from the physician lobbying groups, you can get things covered. It is not as difficult as one would think. And with that, I think I'm going to end, and we'll open it up for all the questions. Okay?
Thanks, Brent. I think we're almost out of time. I think we have time for one question if there is one. If not, I just had one question for Heber, if you could answer this for us, is the current relationship between your hospital and the surgery center and where you see that going forward in terms of the attitude of the hospital towards the surgery center, your ownership in the surgery center, and where you see that going forward for physicians and surgeons.
I think obviously hospitals worry very much about the surgery center becoming a hospital, and so they're concerned about that. And our hospital actually owns a little bit of our surgery center, 5%, and so it's it's a little tricky, but we're a little bit symbiotic right now. I think we're okay, but I think in general the fear is that you turn into a 24-hour stay hospital, and that's a big problem for any kind of standing hospital.
Perfect. Well, thanks very much for your time.